Our first speaker today is Dr. Amir Mian. It is my pleasure to introduce him as our new Division Chief in Pediatric Hematology Oncology here at Dell Children's Medical Center. Dr. Mian graduated from the Alam Iqbal Medical College in Pakistan. He was a resident and chief resident at Beth Israel Medical Center in New York, and his fellowship was completed at Cincinnati, where some of our guest speakers today are from. He went to the University of Arkansas and was medical director at that location, where he also helped to build their transplant center. During his time of building a center and being a medical director, somehow he completed his MBA during that time, and then later went on to be a division chief at the University of Augusta in Georgia, before coming to Dell Children's. Today, Dr. Mian's title of his speech is Prompt Recognition of Oncologic Signs and Symptoms in Primary Care Offices. Please welcome Dr. Mian. The big buttons, the small buttons back there. There is no laser pointer.
Great, thank you. Good morning again. The educational objectives are shown right here. So what I'd like to do is present some of the presentations for in a primary care setting, both not just in the pediatric offices, but also in the emergency department, and that's exactly where most of our patients present. And also just to highlight a few items in terms of what is the best way to follow up these patients. So the primary care office is probably one of the most important sites for the care of our patients. And the reason for that is that's the site where almost 80 to 90% of our patients are going to present, at least up front. And that's the site where the signs and symptoms are going to lead to prompt recognition. And obviously, right after that, it also requires prompt referral to the appropriate subspecialty as well. There are a few elements right at the time of diagnosis which really help in that process, which we'll definitely talk about. This is also, the primary care physician's office is also the place where patients quite often come back and seek support because they've always established a trust with the primary team. And we also rely on the primary care physicians as well for that support as well. And after treatment, even though they are followed up by Peds Hem/Onc for quite some time, most of the patients do return back to the primary care physicians as well for follow-up as well as for the continuous care. So just a few highlights. I'm going to, just because of this time, I'm going to skip through a few things a little bit faster. But pediatric hem/onc is, pediatric at least cancers are relatively rare, as we already know. There's a unique biology for that. And the interesting thing about pediatric hem/onc is a vast majority of these patients are treated on fairly specific standardized protocols through most of the time through Children's Oncology Group. A vast majority of the Peds Hem/Onc patients usually belong in at least 3 different categories, and I'll highlight some of those. It's a challenging field, but this statistic right towards the end, the survival, really gives us time to celebrate and smile because patients, especially pediatric patients, do extremely well, and survival is excellent. And obviously, our goal now is to not just improve survival, but also reduce morbidity for these patients. So this slide just highlights actually 2 points. One, there's this distribution of different types of cancers across the pediatric range. But the second point is leukemias, lymphomas, and brain tumors. They constitute approximately 2/3 of our patients. If we just focus on these 3 categories, we'll capture most of these patients. And that's exactly what I'm going to do for this talk. So the next 3 slides are just going to highlight a few points in terms of age distribution. So this is leukemias, lymphomas, as well as brain tumors during the first 6 to 8 years of life, which you can see as leukemia, as acute lymphoblastic leukemia, has this very sort of specific peak during the first few years of life, and then obviously it sort of evens out. The same thing is to an extent true for brain tumors. Is really a little bit higher predisposition earlier on. And then for the lymphomas, we don't really see a whole lot of lymphomas during earlier childhood, but definitely most of the adolescents that we see end up having lymphomas as well. The other solid tumors, just a different differential over here. Germ cell tumors typically earlier on in life and then during adolescence as well. And then the bone tumors, again, extremely unusual during the first few years of life, but definitely as patients go through the growth spurt, there's definitely biology under that, and we see most of our patients in that age group as well. And then this is sort of striking. The three subgroup of patients, neuroblastomas, retinal, and Wilms tumor, almost always are clustered during the first 5 to 6 years of life and extremely rare thereafter. So again, these are some of those things that we're going to talk about as we move along. So let's just move on to pediatric leukemia. So again, by definition, these are malignant disorders of either the myeloid or the lymphoid origin. About 95% of our patients belong to the acute group, so they could be either acute lymphoblastic leukemia or acute myeloid leukemia, depending on the lineage. And then a very small percent of our patients are going to have chronic myeloid leukemia with CML, which is primarily a disease of adults. Distinguishing features between some of those leukemias. So ALL patients usually present, and they don't look quote unquote sick or acutely toxic. There are obviously different morphologies, and we talked about the peak incidence as well. There are some risk factors associated with acute lymphoblastic leukemia, including prior exposure, chemicals, as well as radiation, patients with Down syndrome as well, along with some chromosomal instability syndromes as well. Myeloid leukemia patients usually are, quote unquote, somewhat more sicker, especially the ones that, recently we have seen they do require a high level of care as well. Again, these are different types, and Down syndrome does predispose these patients. There's a class of myeloid leukemia called GMML, which is very specific to very young infants, and unfortunately, the outcome for these patients is not very good. CML patients generally are actually very normal appearing patients. Most of the time they present with very high white count, 300, 400,000, sometimes even higher. They might have a big liver, big spleen, and few lymph nodes, but they are pretty functional. And there is obviously a cytogenetic that's associated with CML as well. So when we look at pediatric oncology, and especially leukemia, for example, one of the things that's going to be very obvious is they don't really, quote unquote, have any sort of classic signs and symptoms. It's all combination of non-specific constitutional symptoms. And so at the end of the day, we as clinicians have to connect the dots and come up with the appropriate differential as well. So for leukemia, symptoms and signs and symptoms are obviously signs and symptoms of bone marrow failure. So trilineage hematopoiesis is impaired. The white count may either be normal or higher or decreased depending upon the turnover. Hemoglobin usually is always decreased because of the marrow failure, and so is the platelets. And as a result, you've seen all those signs and symptoms associated with that. When the primary hematopoietic system is failing, there is some expansion of the secondary or extramedullary proliferation, and part of that is just the proliferation, and part of that is also entrapment of the leukemia cells as well. So that you might see large liver or spleen along with lymphadenopathy as well. Very classically, we would also see enlarged thymus, which is part of the lymphatic system, and this is where it's really critical for us to recognize it, and it's more important for patients with T-cell, and along with that, there might be some constitutional symptoms. As you can see over here, very non-specific signs and symptoms up front, and all we have to then do is have an elevated concern or a suspicion, and then do the appropriate workup as well. So this is what just a classic patient would look like. So again, non-specific symptomatology, an exam consistent with what we just talked about, and the white count total white count is unremarkable. But what's really important is this differential. So there are a few atypical cells, and that usually is one of those clues to look at the smear and do appropriate workup. And when we look at the smear under the microscope, this is what it looks like. So obviously, there are different ways to analyze this. But on the right side is on my right side is a normal. On the right next to is the abnormal. And once we look at it under the microscope, we can actually have an elevated level of concern, and then do the appropriate workup, which obviously would include flow cytometry as well. So prognostic factors for leukemia, so these are what we call favorable prognostic factors. So a relatively lower white count, so less than 50,000, it is just by consensus by NCI, and this is primarily for B-cell leukemia. So the response is important. Age for us is also important, again, by consensus as well. And then, the involvement of sanctuary sites is also important, but although not that important with the contemporary treatment protocols. The most important ones that we see now is the presence or absence of certain high-risk cytogenetics or translocations, which really can impact the outcome. Treatment most of the time is longer. For leukemia, it's about 2.5 years or so. And supportive care, obviously, is extremely important as well. Long-term outcome, excellent. So for standard risk, about 80-85%. For quote-unquote low risk, it's as high as 90-95%, which is absolutely phenomenal. And there is a high risk for secondary malignancies, obviously, if those patients have received treatment with radiation in the past. And some of the things which are important is there's no known risk factor to the survivors of offsprings, although there are some studies which dispute that. And then obviously there are some long-term side effects that we all have to be mindful of as we follow up these patients. So the key point, just to sort of summarize the leukemia part, is when there's a concern, either in the primary care office or in the ER, this definitely needs emergent referrals. So depending upon where the patient is, at times we would see these patients might be held on in the ER if their patient is really far away, and during that time there might be time to do some lab workup, and this is also time to look at their electrolytes as well, and if need be, to start some fluids in the ER. Again, being mindful that we want to make sure that the hemoglobin is stable enough so we don't really dilute out the really low hemoglobin for these patients. We would tend to start fluids if we were to, without any additives, and then obviously additional labs are there. The documentation for these management is really important for us when we are at the receiving end, so that that should always accompany that patient as well. And one of the things that we've learned over the time is we would not recommend doing some additional quote-unquote diagnostic workup, especially if it's invasive. So for example, would never recommend quote-unquote sepsis workup that would include spinal tap for these patients, just to complete appropriate workup. And also not to give blood products unless we know exactly what we're dealing with in terms of CBC, as well as discussing with the on-call oncologist. And then obviously emergent referral to the appropriate workup is important. Again, this is something that we really like to highlight because once in a while we do see some patients who've received steroids in the primary care setting prior to their diagnosis. So it's important to recognize that steroids can actually mask and probably delay treatment as well. Steroids are extremely potent for leukemia treatment. So once you give them steroids, there is what we call partial remission, and it's lympholytic, so it's going to cause quite a bit of electrolyte imbalances as well, leading on to potential tumor lysis. That could be, for some patients, that may also be life threatening as well, along with renal insufficiency. There's a theoretical risk for resistance as well, and then for us, it might also lead to inappropriate risk stratification, because if we don't know what category the patient belongs to prior to the steroid, then the patient might have to be upstaged just because of that. And then there are some medical legal issues as well that might come up. So again, when we are in this situation, we have to be very mindful of using steroids, especially for all these reasons as well. So let's just move along to lymphoma, to two different subtypes that everybody's aware of, Hodgkin's and non-Hodgkin's. Hodgkin's classically spreads in this sort of fancy geographical spread out. It's got this classic Reed-Sternberg cells as well. Again, various different subtypes. Non-Hodgkin's is more of a systemic disease, along with hepatosplenomegaly as well. So classic signs and symptoms that we're all aware of. I'm just sort of going to zip through it. So constitutional B symptoms are all listed here. Again, these are they might have lymphadenopathy as well. What we always emphasize is supraclavicular lymph nodes they deserve some special attention, along with some additional workup as well. There are some unusual signs and symptoms that we see, especially in adolescents and some older patients, including unexplained pruritus that just does not respond to medical management. And that's primarily because of histamine release as well. So from medical management, when these patients come in, if they've got the lymphadenopathy along with a mediastinal expansion, mediastinal involvement that includes the thymic expansion, what you can see is, especially the patient on the, I mean, it's the same patient, on the top, the picture on the top, the airway, I mean, it's significantly compressed, and this is something that we actually, I wouldn't say quite often, but we do see it once in a while. And this could be life-threatening. So this is a patient, when this patient presents to either the ER or the primary care office, we do want to be mindful that we secure the airway and we are actually aware of the thymic involvement. And that's why all these patients, as part of the workup, do get an X-ray test to make sure that there's no involvement. And the important thing, obviously, it's once you start treatment, within a very short period of time, the airway actually opens up because of the shrinkage of the mass itself. So the non-Hodgkin lymphoma, again, it's a systemic disease, and it really has some very non-specific signs and symptoms up front, and there are some associated risk factors with it, such as, for example, immune deficiency. And Burkitt's lymphoma does deserve extra mention. And Burkitt's, as we know, is one of the, it's relatively rare, but it's associated with EBV. Again, that's a classic presentation. It's really important for us to recognize that it's a very sort of rapidly turn. It's probably the most, the tumor with the shortest doubling time. So within 24 or 48 hours or so, it sort of doubles in size. And it's really important for timely recognition. And it should also be undifferential for any child, a younger child who presents, an older child who presents with intussusception. And we have seen some of those patients as well. The important thing over here for these patients is the survival is excellent. So if we pick up Burkitt's, if we pick up lymphomas, or either in Hodgkin's or non-Hodgkin's, it's actually very curable disease. And for a low stage, the survival is excellent. And for higher stage, obviously, it's a little bit inferior. But still, these patients are salvageable. And that's really important. And that's, that's one of those keys. So again, the sort of take-home messages are pretty similar to what we discussed earlier for leukemias as well, that these patients do need to be referred to the appropriate facility in a timely manner, just from all the things that we talked about earlier as well. So again, this is, I've sort of done that. Let's talk briefly about pediatric brain tumors. There are some associated risk factors, as we already know, and NF1, for example, and TS are two, along with radiation in the past. Survival is excellent. There is decent morbidity associated with some of those brain tumors, but overall, these patients do well. They do have comorbidities later in life. So the things on pediatric, especially for brain tumors, is children are not adults, which we already know. But I think I do want to highlight one thing over here, and which is, again, it's all distribution of where the tumor is. So in children, in pediatrics, a vast majority of our patients actually have tumor which is infratentorial, where in adults, it's actually exactly the opposite. So that's where the distinction is, and that's how the presentation is also very different. So what do we mean by that? Again, going back to our basic neuroanatomy 101, so you've got this tentorium right there in this sort of green area over there. So the vast majority of the pediatric tumors are within this green circle, which includes obviously the cerebellum, the brain stem, and along with the cranial nerve. So you can imagine the symptomatology is going to be predominantly around this area. So the classic signs and symptoms of brain tumors are listed here. Headache is really important. And this is also what we look for. The red flags are headache, which is is usually present early in the morning. It gets better as the day goes by, and it usually is accompanied by vomiting without any associated nausea as well. And there might be some papilledema as a result of raised intracranial pressure, along with smaller patients who might have increased head circumference because of the obstructive signs, and we'll show some pictures as well. Non-specific symptomatology really is loss of milestones, along with some signs and symptoms associated with gait and balance and coordination with or without cranial nerve as well. And very small patients may also have some seizures as they present. So again, a patient who presents with brain tumor, so you can imagine this patient has a large hydrocephalus as a result of obstruction, which is caused by this tumor in the cerebellum, again, infratentorial, and as a result, this patient has signs and symptoms associated with the coordination leading on to headaches as well. So the treatment options are listed here. So a variety of different modalities that are used for these patients. So the key points over here are, there are some red flags that we do need to recognize, and those are the ones associated with in the history as well as in physical exam. And there's no one classic sign that really sort of tells us that this patient has brain tumor or not. Imaging is extremely critical, and obviously there's other patients who definitely then, once we have the diagnosis or once we have a higher suspicion, need to be referred to pediatric oncology. If there's a concern for, once we have it confirmed, and if there's concern for raised intracranial pressure, this is probably one group of patients who do deserve upfront steroids as well to reduce cerebral edema. Again, and after discussion with the appropriate pediatric services as well. And what we do is recommend is once these patients are being transferred over, depending upon where they are, because we see patients from across the state as well, so appropriate documentation along with any imaging that has been done is really helpful, so they don't have to be repeated. And what I always stress is, when we have these patients, we should always highlight that, reinforce to the parents that the diagnosis has yet to be confirmed. So this is the last sort of item that I really want to highlight. And what we have seen, and there's data to actually show over and over again, that obviously for pediatric hem-onc patients, management is important, comorbidities are important, how we treat these patients is important. That's all impactful in terms of outcome. But there's one area which really impacts outcome is prompt recognition, and that's exactly what happens in the pediatricians or the primary care setting. And that's one area that sometimes we don't understand and don't appreciate and don't emphasize enough. And the goal of at least my talk today is to emphasize that this one area really needs to be addressed, because prompt recognition and referral at a time when the malignancy suspicion or the diagnosis is at a lower stage really changes these patients' outcome, which we've already seen. So patient who is at lower stage, the outcome is significantly superior compared to patient who's been referred after quite a bit of a delay because of advanced status. So the survival we already talked about, so I'm going to sort of just move out. But one of the things which is really important is, for example, bone tumors. Again, somewhat difficult to treat, but for those patients who are referred promptly in a timely manner, non-metastatic setting, the survival is reasonably well, 70-75% or so. However, those patients who have been, who've had delay in either referral or upfront recognition, and who presented with metastatic disease, the survival is extremely poor. So that's where I think the prompt recognition and prompt referral is really important. This is also the case for others as well, including lymphomas. So again, the next one or two slides is just a sort of summary of all those things that we talked about. So there are some constitutional symptoms which need appropriate at least workup or referral, depending upon the clinical scenario. Hematological is the same. Lymphadenopathy, obviously, which is not being responsive to appropriate management. Endocrine and unexplained hypertension is equally important for us. And then obviously the patients who are those waking up with significant headache first thing in the morning, all those red flags that we talked about earlier, should at least deserve some imaging upfront. And then there are some patients who might have, especially smaller patients, who might have eye findings as well, and those are really important. And once in a while, we do see some ptosis as well as wandering eyes and things like that, because of the cranial nerve involvement. And again, those are important things for us to recognize within this, within this age group. The masses at unusual places, edema, or some swellings that you would not expect to be there if it stays for too long. I think that also deserves imaging and appropriate referral as well. And then obviously soft tissue, bone mass, tenderness, etc. are equally important. So all in all, there are some non-specific signs and symptoms which should elevate our suspicion to do appropriate workup, and that is exactly where the primary care physicians and the primary care offices really are most impactful, because that appropriate recognition and timely referral really leads to timely diagnosis at a lower stage, hopefully, and that really, if you've already seen, changes the outcome, and it's really impactful. So with that, I'm going to thank you all, and I appreciate the opportunity to present, so thank you.